Welcome, Frank, once again. So, um, as you know, Dr. Frank Brennan is one of the pioneers of renal supportive or palliative care. And as you know him already, I am not introducing him again. So I am straight away.
Dr. Sunil? Dr. Frank, I think you can start over.
Okay, let's see how we go here. So I'll just share the screen. Now, I might just ask you, can you see the title slide?
Yes, I can see it.
Good. And I'll just see if it moves.
Yes, it is moving.
Perfect. Thank you. That's lovely. Very good. So welcome again, everyone, to the third in this series on symptoms and CKD. As you remember, the first lecture was really a background in terms of kidney supportive care. What is it? Why does it exist? Why is there an emerging alliance between nephrology and palliative care? The second lecture was the first of the symptoms, and we talked about several symptoms there, including uremic pruritus, fatigue and restless legs. Today, I'm going to concentrate on several other symptoms: pain, shortness of breath, insomnia, and taste changes. Let's start with pain. An 81-year-old dialysis patient says to you, "I have pain all over my body." Now, that's an expression we sometimes hear from patients, and perhaps just indicates of how significant pain can be. I'll come back to her a little bit later. So we'll talk about the prevalence of pain in kidney patients, causes of pain, and an approach to pain management. Pain is a common symptom experienced with patients with advanced kidney disease. Epidemiology. So look at this remarkable figure. Over 2/3 of hemodialysis patients reporting pain in that large study looking at 19 separate studies. About 40% report the pain as moderate to severe. Data on non-dialysis patients or conservatively managed patients is, more limited, but does show similar prevalence and severity figures. Pain, as we all know, because all of you have been very educated in cancer pain in terms of palliative care, but pain does have an extraordinary impact on function and quality of life. Data from 9 studies representing about 2,100 hemodialysis patients found that pain was associated with lower quality of life. Davidson back in 2002 looked at about 70 dialysis patients. 62% said that pain interfered with their ability to participate and enjoy recreational activities. So you can start to see that, yes, the symptom is there, but it's also having an impact on quality of life, function, and really the whole enjoyment of life. And look at this figure, about half reporting the pain that caused them extreme suffering. And this extraordinary figure of 41% saying the pain was so difficult that they would consider stopping dialysis. So that perhaps indicates the severity and the difficulty people can go through. Pain with CKD patients has a positive correlation with depression. It's independently associated with missed or shortened dialysis sessions, where people just are in pain and can't get to dialysis or feel they have to get off a dialysis chair. Accident emergency presentations and hospitalizations. So what are the causes of pain in advanced kidney disease? Well, look, I think there's 3 main categories, if you like, or 3 main headings. pain relating to the kidney disease itself, the actual reason why they've got kidney failure, pain relating to the treatment of the kidney failure, and pain relating to the comorbidities. So what about the kidney disease itself? So there's several major causes of pain here. Polycystic kidneys, where the cysts in the kidneys start to, in this particular disease, you get cysts in the kidneys that start to expand and grow, and they can push up on the viscera and even down onto the lumbar vertebra, so big they can be. Renal bone disease, amyloid associated with kidney disease, including the carpal tunnel syndrome, and also calciphylaxis, an infrequent, in fact, a fairly rare but very feared complication of kidney failure, where you get calcium deposition in the intima of small vessels, ischemia, small areas of ischemic, blackened ischemia on the skin, which start to grow. It's associated with extremely difficult pain, really difficult pain, associated with high mortality. Occasionally can end up with having had people needing to have amputations. Pain secondary to the treatment of the disease. So this could be peritoneal dialysis patients with recurrent abdominal pain. The AV fistula may cause the Steele syndrome. So this is the fistula for hemodialysis patients that's formed in the forearm, just here. But if there's not quite enough circulation coming into the tips of the fingers, you may get ischemic pain or stealing the circulation, if you like. You can get cramps during dialysis or outside of dialysis, intradialytic headaches. So there's quite a few things that can be the source of the pain is the actual treatment. And then, of course, you've got a huge number of comorbidities that people may experience: osteoarthritis, diabetic peripheral neuropathy, peripheral vascular disease, ischemic heart disease, cancer pain, etc., etc. This list can go on and on. So it potentially might be that a person may have, as that 81-year-old who said, I have pain all over my body, pain in multiple different sources of the pain. So what's our pain etiquette? Well, look, we learn this from general palliative care, don't we? That we need to inquire regularly of patients, respond compassionately, treat competently, and if we're not sure how to treat, then refer on to other clinicians who hopefully can help us in terms of treatment. So let's talk about pain management in patients with CKD. Unfortunately, there's a lack of direct evidence in this cohort. There are very few studies on pain management in CKD patients. Of course, in the general population, there's a large number of studies in malignant pain, non-malignant pain for the general population, but in this population, very little. So I think we need to work towards a strategic approach to pain management in these patients. First of all, you come back to the strength of this audience because you have a good understanding of the basic pathophysiology of pain, and that's a really good place to start. So pain simplistically could be nociceptive or tissue pain or neuropathic relating to nerve damage. Now, there are other classifications, but I think this is quite a good way, especially for nephrologists who have not been trained in pain medicine, to start to differentiate what pain they're treating here. So there's an increasing, although not complete, understanding of the pharmacology of analgesic medications in CKD and dialysis. This, to me, I think is probably the best paper in this area, written by Sarah Davidson, a nephrologist from Canada, who's a leading light in kidney supportive care generally. Clinical pharmacology considerations in pain management in patients with advanced kidney failure. The CJSON, the Clinical Journal of the American Society of Nephrology, back in 2019. So if there was one paper to look at, I'd go to this paper. So what does Sarah Davidson talk about? How does she then manage pain? Well, she starts with a very cautious stepwise approach. So as you can see, this very traditional, perhaps, sense of pain, nociceptive, neuropathic, and working her way through the various ways of dealing with this. In the nociceptive, acetaminophen is paracetamol, Panadol. She goes to a maximum of 3 grams. That's interesting. That's smaller than what we would normally do. and then other agents that may be useful and then eventually may get to an opioid. With the neuropathic pain, well, she's doing a very traditional way, of course, of looking at gabapentinoids and other medicines there, and eventually moving to an opioid. I think a critical thing she's doing is getting nephrologists away from the idea that all severe pain needs to be treated with an opioid, because that's not necessarily so, particularly neuropathic pain, that you may be using other agents such as gabapentinoids and other medications here well before you even think of an opioid. Example of this approach. Let's talk about diabetic peripheral neuropathy. Currently, there's no evidence-based or consensus guidelines on the management of pain for diabetic peripheral neuropathy in CKD. As we said, the cupboard is bare, really. And look at this remarkable quote: clinical evidence regarding the effects of analgesic agents to treat diabetic peripheral neuropathy in this group of patients is virtually non-existent. Now, that was published back in 2010. Not much has changed since then. So we do know in this situation, diabetic peripheral neuropathy, the pain is neuropathic. And even though there's very little in CKD, there's a significant body of literature in the management of pain for diabetic peripheral for the general population. That literature includes several international evidence-based guidelines. And that's consistent with what Sarah's doing here. Those guidelines move you very quickly to the gabapentinoids and other agents rather than going straight to opioids. So we'll come back to Our Lady. What's actually happening here? So I met her some years ago, and I was just struck by how suffering she was, but also how complex the story was. Yes, this pain was all over her body because she had multiple different reasons for pain. She had gouty arthropathy, osteoarthritis, diabetic peripheral neuropathy, post-herpetic neuralgia, and postoperative pain. No wonder she was getting so much pain. But I also realised and came to realise over time that simply because her pain was severe, that I shouldn't use an opioid to control all of these pains, because opioids would be relevant to some of these, but not everything. So I just think perhaps that's the take-home lesson. With pain and CKD, to separate, to work out exactly what is the cause of the pain. Gouty arthropathy, osteoarthritis, etc. Then work out, okay, what is this nociceptive or neuropathic? And then start to work your way through it. Gouty arthropathy is a good example because the treatment is not opioids, but using prednisone, steroids. Post-herpetic neuralgia, well, you're not going to go straight to opioids, or you may or may not, but you may well go to anti-neuropathic agents, etc. So I think the approach is to separate each cause of pain. Think of the best evidence for each pain syndrome, and as a general approach, separate the pain into nociceptive versus neuropathic. And that will avoid the story of putting every single patient with CKD and pain on opioids. Okay, well, let's look at the common analgesic agents in kidney failure. Paracetamol. Well, paracetamol is safe in kidney failure. Metabolized in the liver, inactive metabolites. I don't adjust. I use 1 gram 4 times a day, but Sarah Davidson advises 3 grams a day maximum. So that's interesting. She's been careful. So potentially you could move to Sarah's recommendation there. It is considered the non-narcotic analgesia choice of mild to moderate pain in CKD patients. NSAIDs. Well, we do not use NSAIDs if the patient's on a non-dialysis pathway, because that's going to really upset the kidney, the remaining kidney function, and may well cause a significant deterioration in kidney function. And you're trying to preserve the kidney function. So we don't use it in the non-dialysis group. And also there's recommendations not to use it for people over 75 years old. So there is, with non-steroidals, there is an increased risk of bleeding and cardiovascular events. In hemodialysis patients, where there may be there's almost no renal function at all, and they may and you're not going to damage the kidneys, then it may be that you could use, and I always call the nephrologist just to talk with the nephrologist to see if it's okay. Sarah says it is best reserved for specific indications for acute pain, limiting their use to the lowest effective dose and short duration. So that's a possibility you might use them. tramadol? Well, Sarah's has actually categorised this as an analgesia to avoid in kidney failure. Now, that may come as a surprise to people because it is used in kidney failure. Really, you need to be very careful with its dosing, but I think she summarised the side effects and the complications of tramadol. And she said, even with, well, I'm summarising here, even with cautious dosing, to be very aware of drug interactions and especially the so-called serotonin syndrome. So we tend not to use tramadol, which, as you know, is a weak opioid. Codeine. Well, the trouble with codeine is it's metabolized in the liver into morphine and norcodeine. Now, it's the morphine story that's the trouble, because morphine, if you give morphine to a patient with chronic kidney disease, especially kidney failure, that morphine is metabolized itself in the liver into metabolites that are excreted in the kidneys. And if the kidneys are not working, those metabolites build up and can cause toxicity. So I'll come to morphine just in a second, but that's why this story with codeine, and also codeine having reports of profound hypotension, CNS and respiratory depression. She says it's not recommended in CKD. Okay, coming back to morphine, and we've just spoken about that, how those metabolites of morphine, morphine 3 and 6-glucuronide accumulate in kidney failure, and particularly M6G can cause significant toxicity. So in general terms, we do not use morphine. There's the metabolite building up and coming into the kidneys. However, it is understood that around the world, there are a lot of places, a lot of countries that may only have morphine as the one and only strong opioid. And what can they do in kidney failure patients if they cannot use morphine? So what they tend to do is to use morphine in very small doses and widely spaced apart. So normally, if the person's got normal renal function, you'd give liquid oral morphine every 4 hours, as we know. But in kidney failure, you may make it every 6, 8, or even 12 hours, so widely spaced apart. So while there's a recommendation and a recognition that in many nations, the only strong opioid is morphine, the recommendation that not to use morphine is set aside. And doctors do use morphine in very small spaces, in small doses and widely spaced apart. Interestingly, in certain areas of Africa, they describe it as renal dose morphine. That's interesting, that expression, isn't it? Renal dose morphine, small doses, widely spaced apart. So that's starting to be understood around the world. Hydromorphone. Well, hydromorphone is okay here. Hydromorphone's also metabolized in the liver into hydromorphone 3-glucuronide, but H3G is much better tolerated than those morphine metabolites. And so it's less neuroexcitation. So we do use it in low doses and we start to monitor it carefully. So we might start using hydromorphone, say 0.25 milligrams QID. Now that's a very small dose. Then maybe building up to 0.5 milligrams fourth hourly. But bit by bit building it up, I find it quite well tolerated. And as you know, hydromorphone is 5 times the strength of morphine. So 1 milligram of hydromorphone equals 5 milligrams of morphine. So commence low, if tolerated, build up to 4 hours. Once the person is feeling better, the pain is better, you may move on to a safe, long-acting opioid. So I think that there's general agreement that it's okay, starting with small doses and building up. Oxycodone. Now, this is really interesting because Sarah Davidson has shifted in her own writing. In 2014, she felt that it would be okay to use oxycodone in small doses. And this is where I sit as well. I also use oxycodone in these patients, but small doses and slowly building up. In the last paper, she's put it in the category of opioids, analgesia to avoid. So she's talked about the I guess, the evidence has started to accumulate on oxycodone in CKD and dialysis patients. And I guess a caution that's come into her writing there. So I suppose it's really a question of what you do or what you've seen done. I think it would be reasonable to use in small doses and building up, but just be aware that there can be side effects, mainly opioid toxicity and other things. Fentanyl. Okay, so fentanyl is a good news story here because fentanyl is metabolized and those metabolites are well tolerated. And also fentanyl is not dialyzed. So if you put a fentanyl patch on, you don't need to be chasing the pain thinking that it's going to be dialyzed off. No, that's okay. Metabolized in the liver, inactive metabolites, very small amount unchanged, excreted unchanged renally, and it's not dialyzed, so it's quite an okay. But as you all know, in palliative care, we don't rush to fentanyl, putting a fentanyl patch on, particularly an opioid naive patient, someone who's never been on opioids, because it can rapidly accumulate and cause toxicity, even in the smallest fentanyl dose. So we usually use it after we've used short-acting opioids building up, then we put on the fentanyl later. Buprenorphine, the Norspan patch, metabolized. Yes, look, I think that there's a general sense, certainly Davidson in 2014 thought it was fine. So we do use Norspan or buprenorphine patches in small doses. The smallest we have here is 5 micrograms. But yes, you could use that and be just careful there. Methadone. Now, methadone is a very interesting medicine, and it's also has a good news story here. Why? Because most of methadone is excreted fecally rather than through the kidneys. And also, it is not dialyzed like fentanyl. However, and it's a big however, of course, is that methadone has a very unusual metabolism where it accumulates over time and really does require the skill of a palliative care or a pain medicine physician. So we have been using some methadone over the years, particularly in very, very difficult neuropathic pain, to good effect. And this is important too, isn't it? Everyone should be aware of that, as you know. Okay, let's move on to dyspnea, shortness of breath. What is happening here? So shortness of breath probably has two main headings, if you like: renal-related causes and secondary to comorbidities. The renal-related causes are, first of all, anemia and fluid overload. The comorbidities would be primary lung diseases or primary cardiac diseases. Let's start to talk about the first, renal-related causes. So I suppose just before we jump into that, the two main principles of management are, first of all, to diagnose and manage any reversible cause of the dyspnea and the general management strategies of dyspnea. And that's probably a good way of approaching here. Okay, so we've got the anemia story. Now, why is anemia such a big story here? Well, erythropoietin is produced by the kidneys. So if you've got kidney failure, you are going to get reduced erythropoietin over time, and you are going to get anemia over time. That's why it's so important in kidney failure. So when patients get anemic, they may well get short of breath. I guess with anemia, we check the serum iron, vitamin B12 and folate, but particularly look at the erythropoietin story. So in dialysis patients, the aim is to keep the hemoglobin between 100 and 120. And really what happens is people are given erythropoietin supplements, okay, to keep that hemoglobin in that range. In the non-dialysis patients, we may not be rushing to giving erythropoietin, but just simply treating according to symptoms, such as dyspnea, fatigue. patients in fact may tolerate a lower hemoglobin. And indeed, that globally there are issues of accessibility and affordability of erythropoietin products. So this is a major story in terms of renal medicine, the erythropoietin, the anemia that can follow, in dialysis patients trying to keep the hemoglobin in that range, usually using erythropoietin. For non-dialysis patients, not rushing towards erythropoietin, but according to their symptoms if necessary. But now recognising that around the world there are issues in terms of accessibility and affordability. What about transfusing patients? Well, look, we need to be very careful about transfusing a renal patient there, because that may precipitate acute pulmonary edema in two situations, when the patient is having inadequate dialysis and in the terminal phase. So we're careful about simply just giving a blood transfusion. We'd have to be a bit careful there. Fluid overload. Okay, so this is quite the story there in renal medicine. In this population, this may be due to both renal and cardiac causes. So how the nephrologists respond to this with fluid overload is using loop diuretics, although clinicians often move to what they call a sequential blockade. A sequential blockade consists of a progressive increase in sodium depletion using different diuretics acting on three segments of the renal tubules. So, for example, using medicines like furosemide, spironolactone, and then amiloride, basically one after the other, just lift one dose, prescribing one, okay, then adding another one, and then adding another one, what they call sequential blockade. So that's often what the nephrologists do. When CKD is stage 5, sequential blockade may not be as effective because the kidneys are very, very weak now, and you're trying to press on, you're trying to activate these renal tubules, but it may be it's very difficult for them, and it may be less effective. So you may start to see the nephrologist using higher and higher doses of furosemide, very high doses indeed, or butyramide. Which is another one of trying to get rid of fluid there. But it may not be fantastically successful, but it's certainly done. Be aware that in resistant cases, there may be gastrointestinal edema and concern about the absorption of oral furosemide. In that situation, sometimes they use intravenous or subcut furosemide. What about the context of acute pulmonary edema? Well, we're taught at medical school and as junior doctors how to treat acute pulmonary edema, so this is not going to be a surprise. Using oxygen, diuretics, nitrates such as a GTN infusion, opioids, and possibly CPAP, but not always, but that's certainly a possibility. So fluid overload may be secondary to excess intake of water or sodium. Now, the excess sodium may precipitate severe thirst and excess fluid intake, so it can be a vicious circle here. Now, so the excess water intake, often, but not always, often renal patients are advised to be very careful about how much fluid they're drinking. But that's very, very difficult if they're in a hot climate and they're thirsty, and especially if they're having food that's got lots of salt in it, because they're thirsty and they'll just drink. And when they drink, they may get very fluid overloaded, and this just gets into a cycle. So you can see how quickly, potentially, a person may become fluid overloaded, but not necessarily. It's not always the story. And people try to do their best to hold their water intake to a reasonable amount. Other teaching points here. It's important to be aware that in cardiorenal failure, where you've got both organs failing, it's sometimes the need is to sacrifice some renal function towards achieving volume control and low symptom benefit. So I'll just explain that. If you've got both the heart and the kidneys failing, and you've got fluid overload, well, I think the main thing to do is to try and get rid of that fluid as much as possible. But of course, that is putting more pressure on the kidneys, so you may end up having worsening kidney function. cardiologists and renal physicians seem to be comfortable with that because they're realizing this is quite a very difficult story, and they're aiming for the comfort of the patient. So they realize they may sacrifice some renal function by doing this. Also, in our experience, patients with kidney failure on a conservative pathway, a non-dialysis pathway, or having been withdrawn from dialysis do not drown in fluids. People sort of think that's what's going to cause them to die, but we rarely see that. Invariably, they die of progressive uremic encephalopathy, tiredness, all the way through to a coma on a background of functional decline and cachexia. So it's very rare we see people in extraordinary fluid overload situations, but we've spoken about how we try and manage it just in the previous slides, of course. Now, then you talk about, so we've talked about specific managements of dyspnea in the kidney situation. Now talked about general management strategies. And as you know from general palliative care, there are some palliative measures for difficult dyspnea that have good evidence base, and they include, number one, small dose opioids. Here, potentially the dose, say if you were going to use morphine, well, that would be pretty safe because the morphine dose is going to be very, very small anyway, maybe 1 to 2 milligrams, maybe a little bit more, or a small dose of hydromorphone. Small dose benzodiazepines sublingually. That's going to be very helpful for the anxiety associated with shortness of breath. And also you've heard about the handheld fan, having a fan near the face. That can be very helpful for shortness of breath. So we do those specific strategies for dyspnea with renal patients, and also these general strategies that we would use for any patient with shortness of breath. Insomnia. This may be the product of multiple other symptoms. And just have a look at the numbers of things people might be keeping people awake at night. So if I've got a patient who's describing themselves, they're not sleeping well, I'm going to ask them, first of all, tell me exactly what happens with your sleep, because occasionally people say, I'm not sleeping well. In fact, they're sleeping quite well, but they've got that impression. Then, if it's clear that they are not sleeping well, I'm going to ask them why. What is happening at night? I'm going to do a very clear sleep history or nighttime history, because it may be that they've got undiagnosed things like restless legs or cramps or itch, nocturia, sleep. So they might have lots of different things maybe disturbing their sleep. So I'm trying to get to the source of why they're so sleepless. That's a very useful thing. It may be that everything is fine, that there's actually no underlying cause, and it's a bit of a mystery as to why the person's got insomnia, but it's worthwhile asking. It's very interesting that a study showed that the evening surge of melatonin that controls the circadian sleep-wake cycle is absent in dialysis patients. So that's fascinating, isn't it? That really what's happening there is quite extraordinary, really. So that's why we are now much more in favour of using melatonin as a way of dealing with sleep in these patients, sleeplessness. Also, look at this figure. 254 hemodialysis patients, 57% had moderate to severe sleep apnea. So that's a whole story there. And we just need to work out what's going on and potentially looking towards doing sleep studies. If you're suspicious of sleep apnea, doing a formal sleep study. What are the general measures for insomnia? No caffeine after lunchtime, alcohol at night, no alcohol at night, no smoking at night. Potentially using melatonin. We might start at 2 milligrams, 4, and then build up to 4 or 8 or say 6 or 8 or even 12 milligrams at night. Tonazepam, 10 to 20 milligrams at night, something like that. But I'm first of all, before I'm rushing to prescribe those medicines, I need to take a very clear night history. What is happening at night? Because it may be that there's something that sits there that the patient has never discussed with a doctor before and is undiagnosed or very difficult for them, such as itch, such as restless leg syndrome. Let's now finally look at taste changes. An 80-year-old woman with kidney failure secondary to ischemic nephrosclerosis. She is on a conservative non-dialysis pathway. After many clinics, she reports no taste for a long time. She states, I really need to force myself to eat. My taste is gone. Is this common or uncommon? It's one of the most disabling yet neglected symptoms of patients with CKD is taste changes. So in this short passage now, I'm just going to talk about what actually is taste, the anatomy and physiology of taste, the epidemiology of taste changes in CKD, why this occurs, and management strategies. So the anatomy and physiology of taste. Taste can be usefully summarized as salt, sweet, savory, otherwise known as umami, sour, and bitter. The human tongue. On the surface of the human tongue are numerous taste buds. The taste buds are a group of chemoreceptive taste receptor cells. There are three main taste cells. Type 1 cells detect salt taste. Type 2, sweet, bitter, and umami taste. And type 3, sour, and in certain circumstances, salt taste. So here are the three cells. What are the classic taste stimulants? Well, to a salty taste would be sodium chloride, of course, salt itself, setting off salty. Glucose, setting off a sweet taste. Meat and glutamate, setting off a savory or umami taste. Caffeine, or in this case with kidney disease, urea, can set off a bitter taste. Acids, such as vinegar, lemon, lime, the acetic acid, citric acid, that may set off a sour taste. Sweet taste. So sweet taste is the strongest suppressor of other tastes. It is also the most resistant to being suppressed itself. Bitter. Humans have a natural aversion to substance with a bitter taste. It's an evolutionary protection to us. So if it's bitter, often people just don't want to taste it or put it out of their mouth because that protects you against toxins that may be lethal. Umami taste. A common example of umami taste is glutamate that is found in meat and mature cheese. Sour taste. So this sour taste is perceived when hydrogen ions cross the hydrogen channels, the type 3 taste cells, citric acid in fruits, and acetic acid, vinegar. Human saliva. Well, the normal saliva is very important in terms of taste. Virtually all of it, about 99%, is water, and the remainder a combination of electrolytes and proteins. Normal saliva is hypotonic, high in potassium and phosphorus, and low in sodium and urea. Now, when the person has kidney failure, this completely changes. There's a big, profound change in the composition there. And I'll come to that very soon. Zinc plays an important role in the maturation, maintenance, and repair of taste buds. Taste, flavour, and chemesthesis. Taste is a single, albeit extraordinarily complex sensation. A wide variety of chemical compounds act on the mucosal membranes of the mouth. Now, this is separate to the tongue now. This is not to do with taste. This is things like heat, cold, pungency, irritation. This is called chemesthesis. So examples within the oral cavity include the heat of chili, the irritation of wasabi, the cooling of menthol, and the astringency of tannins in tea. So this is a very fascinating story of the so-called TRP channels, which pick up all these different extra sensations, if you like. Flavour, when you talk about flavour of food, that's a combination of taste, smell, and the sensations of temperature and texture. And is estimated that approximately 3/4 of flavour is produced by odorants, the smell of the food. While the sensations of taste and smell are distinct, their signals are integrated into the frontal cortex and to generate flavours. The language of taste alterations, well, absence of taste is agousia, reduced taste, hypoagousia. Taste disturbance is dysgeusia, things like metallic taste or unpleasant, and exaggerated taste is hypogeusia. But dysgeusia or hypogeusia is the story we're going to really talk more about. So what happens with chronic kidney disease? Okay, taste alterations are common in patients with chronic kidney disease. People start to talk about different taste changes. I've got no taste or bland taste, metallic, bitter, or a mixture of tastes, and they may also report malodor. What's our experience? Well, over several years, we've been asking patients about taste changes. And when we first asked this question, this remarkable figure, about 40%, both dialysis and non-dialysis, are reporting an alteration in their taste. What's the severity of that? Well, as you can see, about 43% slight, but 39% plus are reporting moderate to overwhelming sense of taste changes. What descriptor do they use? Well, mostly bland. They've lost their sense of taste, but it may be bitter or metallic or other things as well. Why does this occur? Well, we actually don't know, but several facts are known. First of all, there are changes in salivary flow, salivary composition, and salivary pH. Salivary flow. The literature on this is a bit divided. Some saying that the salivary flow is reduced, others finding no salivary flow reduction. Patients with CKD may be susceptible to fluid overload or dehydration, secondary to fluid restrictions and frequent use of diuretics. When the body water content is reduced by 8%, salivary flow decreases almost to zero. Okay, this is particularly relevant for those treated with dialysis, as this treatment results in substantial body fluid level fluctuations. The level of hydration is directly related to salivary secretion. Dehydration leads to reduced salivary secretion and higher concentrations of salivary solutes. So this is interesting, isn't it? Fluid restriction, dialysis, all these things playing a role here. What about, now remember I said that the normal saliva has changed hugely in CKD. Well, first of all, you're going to get an increase in sodium, an increase in potassium, increase in bicarbonate, and an increase in urea. What's that going to do? The sodium is going to set off salty taste, but in high levels, it may actually reduce sweet taste. High potassium, going to set off a metallic taste. Bicarbonate, loss of sour and umami taste. And also with urea, at the beginning, it's a bitter taste, but eventually it switches off the taste. So that's probably why things are so challenged. Salivary pH, normal salivary is slightly acidic. Studies have found that saliva patients' kidney failure is more alkaline. So in summary, there are changes in the saliva in CKD, though there's different results in those studies, but certainly the second one, salivary composition, is very changed, setting off a pattern there in terms of the, what about a practical example? Meat aversion. Well, it's been observed that with kidney failure that many people just don't want to eat meat. Many CKD patients describe an aversion to meat. In a survey of EGFR under 25, 36 reported that they avoided specific food, especially meat. Bisolar study, food aversion, university report, and aversion to meat. So why is this happening? Well, the inability to identify umami or savoury taste can explain this, and there are several possible reasons this may occur. First of all, there's an inverse relation, ability to detect glutamate and the sodium bicarbonate. Salivary bicarbonate removes sodium ions. A reduction of sodium ions decreases umami perception. Genetic variations in taste and age also may play a role. So there's quite a few reasons why someone may have an aversion to meat. How do we manage taste alterations? Well, look, the level of evidence is low here. A recent Cochrane review said, well, very low quality of evidence. Okay. So the only intervention that has been subject to RCTs here is zinc, the so-called zinc studies. And they are mixed results. 2 crossover in 1 parallel arm, studied the effect of zinc sulfate on taste disorders. The authors of the Cochrane review concluded that overall there's limited evidence and the primary outcome, taste acuity and discrimination, is not conclusive. So yes, so it's not clear. Mouthwashes. This is interesting. This may very well help. This was an intervention where people had upper GIT symptoms and a huge percentage had taste changes. And so this Karen Manley, a dietitian, a nutritionist, what she did is she gave water mouthwashes, salt mouthwashes, sodium bicarbonate and citric acid. So given these patients who had poor taste. And sodium bicarbonate produced the greatest improvement in taste. So that's what we're advising people to use some sodium bicarbonate mouthwashes. So in the absence of studies, 2 phenomena have quietly unfolded. First of all, renal dietitians are now starting to work out what they would recommend, but it's mainly empirical. And also, and what they do recommend is the sodium bicarbonate mouthwash. But also what's happening is that patients and families are choosing their own food and drink to shift to or shift away from to try and get a bit more taste, particularly if they've lost taste. So that's interesting. This is not a medicine then, but a change in diet. So patients with taste alterations naturally shift their taste preferences. Example include the person with a bitter taste gravitating to sweet foods and drinks, salty taste avoiding salty foods, absence of taste preferring foods that stimulate taste such as chili or spices. That's interesting, isn't it? So whether based on professional advice or naturally reached, do these empirical approaches have a basis in underlying pathophysiology? I think they do, because it's basically working out almost unconsciously, people working out what food and drink will stimulate some taste in their mouths. So future management strategies may not be simply waiting for medicines, but carefully adapting the diet according to mechanism. This is a lot of information to hold in mind. So could this information be brought into a simple clinical tool? So we've developed what we call the CKD taste plate. So if you look at the inner part of that plate, you can start to see what the patient is saying. I've got no taste, salty, metallic or bitter. Then if you look at the outside edge, are the recommendations that we're making for those patients. So this is perhaps a useful tool for people to have at the clinic, so to show to people, if you've got no taste, try this, bitter, metallic or salty. And so we published that in the Journal of Renal Nutrition in 2022. So what are we going to do for our lady? My taste is gone. Well, what we could do is come back to that taste plate, say she's now saying she's got no taste, and then starting to work our way around those recommendations. So what we do is we say, look, why don't you try cooking with some chili or spices, vinegar, marinades, maybe even try cooking with honey to stimulate a bit of sweet taste. Obviously, we need to be careful with diabetics. Also a bit of acidic foods to activate the sour taste buds, and maybe trial maybe some zinc. If the person said, I've got a metallic taste, where we take away metallic cutlery, take away metal cutlery, and that can be a very helpful thing as well. To what extent do these taste symptoms contribute to upper GIT symptoms? Well, I think that the answer is yes. There's a complex interaction between taste changes and the upper GIT symptoms. So again, we've looked at this and we've tried to see what sort of association there is between taste changes and upper GIT symptoms. And we found that taste changes, there's a high prevalence of taste changes in malnourished patients, nausea, vomiting, anorexia, etc. So I think that you can start to argue that it may be that taste changes is one of the perhaps critical elements setting things off. So you can start to see the symptom burden in dialysis patients, the taste changes, and those other symptoms there. So in terms of the effect of taste alterations on the nutritional status, the main study, particularly if the person's not wanting to eat at all, is poor nutrition increase in all-cause mortality. So while taste alterations are not the only cause of upper GIT symptoms, they do, when present, contribute to these symptoms. So I'm not saying that taste alteration is the only story here, but if you do have a taste alteration, you may start to get a cascade of anorexia, I don't want food, nausea, particularly with bitter taste, early satiety, and leading to weight loss and malnutrition. So it may be that if you can help with the taste change, that might help them overall. So given those close associations and the emerging understanding of taste, it may be that we can help with taste, might help those upper GIT symptoms. Okay, so that's good. I've finished now the lecture. Thank you so much. I'm happy for questions.
Thank you. Thank you, Frank. The session is open for discussion now.
So you can type your questions in the chat.
While I'm waiting for questions, that story about taste is, to my embarrassment, not something that I'd been looking at for a long, long time. And it was only in recent years when patients start to say, I'm not troubled by pain or nausea, but I am troubled by my taste. What can you do about it, doctor? So it got us very intrigued about the frequency, and you see the prevalence figure, around 40%, and the pathophysiology of why taste changes are occurring, and then got us on to start to look at that, designing that taste plate. Okay, so the question that's coming up here, can we use fentanyl patch for pain? Oh, now the question's just disappeared. I think, was the pain in terms of, maybe if you could read the question out again.
Can we use fentanyl patch for pain not responding to paracetamol?
Oh, okay. It's a really good question. The first thing is to work out what is causing this pain, because it may be that that you may not necessarily be using may not necessarily be using an opioid at all, particularly if it's very neuropathic. But if you're getting into a situation where you think, okay, Panadol may be useful here, but it's clearly not enough, I guess the question is where you go from there. And I would be certainly thinking, is this nociceptive? Is this neuropathic? And working out where you're going to go. Because fentanyl patch is quite a big step to make, and especially in an opioid naive patient who's never used opioids before, I wouldn't do it straight away. If you were thinking, yes, opioids are appropriate here, you may build up with a short-acting opioid and maybe then fentanyl later. But yes, that's usually the answer there.
Another
yeah.
Sister Sushma asks, many times patients refuse to eat anything else. So how we can manage it?
Sorry, I just maybe to repeat the question. Many patients are
they refuse to eat anything.
Or refuse to eat. Okay. Refuse to eat. Okay. I'm going to, in the next lecture, talk about anorexia, nausea, vomiting, and I'll certainly touch on anorexia. But what I would do in answer to that question, I would start to ask about what's happening with their taste, because it may be that one of the reasons they're refusing to eat is that they've lost their sense of taste. Now, or it may not be, but at least just to check on them whether taste has changed. And if taste has changed, trying to perhaps use some of these techniques or different foods or drinks to try and stimulate a bit of taste. The other thing that they're refusing to eat is that they're nauseated. So I'll turn to that in the next lecture, but yes, trying to deal with why it is that they're refusing to eat. Anorexia is basically, as you would imagine, very common in this group of patients, and it can be very debilitating. And sometimes we use what they call supplementary drinks. Nephpal is a classic one, other ones for kidney patients, but I'll turn to that in the next lecture. Thank you.
Yeah, another question is about liver degeneration and use of morphine and gabapentinoids together.
So the question is to do with the use in renal patients of morphine and gabapentin?
Liver degeneration. In liver degeneration, how do you use morphine along with the gabapentin? Or can we use?
Okay. Okay. So the question is, can we use both morphine and gabapentin together? Okay, the answer is yes. Yes, it is possible, of course, to use those two medicines together. Now, of course, you have to be very careful with dosing, in kidney failure patients. We've already spoken about some authorities saying do not use morphine at all. And if you are going to use it very small and widely spaced apart. With the gabapentin, again, you have to be very careful with the dosings, as we saw in the last lecture. So it's not like a normal patient, like patient with normal renal function. So we have to be very careful in terms of that. But yes, the answer is you potentially could use both medicines together.
Frank, the usage of morphine and gabapentin in liver degeneration, not in renal diseases.
Oh, and liver disease. Oh, is that the question? Is to do with liver disease? Oh, liver disease. Okay. Well, okay. So, look, certainly morphine is metabolized in the liver, but usually the liver is able to continue to do that, I suppose, until it's extreme, like it's failing, I guess. You may have an issue there where the morphine itself is having a slow metabolism. But it's really, I think, morphine and gabapentin could be used in liver disease. Yes, absolutely, they could be. But then I suppose the question then is what's going to happen to their metabolites, and it's the kidney disease that's going to be perhaps the more of the story here. But yes, you could use morphine and gabapentin in liver disease, but except I suppose if the liver is completely failed, that might be an issue then.
Yeah. Another question is about end of life care. You told that uremic encephalopathy is commonest cause for patients to die. So if the family members ask about what should they expect and what should be the informed answer that we should give them.
Yeah, this is a really good question. And this will also come up in the last of the lectures, next lecture, where I talk about the care of the dying patient. So uremic encephalopathy, yes. So that's going to come at a point when the uremic toxins start to build up. It starts with drowsiness, tiredness, all the way through to a coma. What you can expect over time is you may start to get uremic jerks. You may rarely get seizures, and you may also get confusion. So there's various things to speak to the family about. And I will, in that lecture, next lecture, I will talk about how to manage those and the discussion with the family, yes.
Is there a serum creatinine level up to which morphine can be used?
Is there a
serum creatinine level up to which morphine can be used?
That's a really interesting question, isn't it? Because presumably there must be a sort of a point where, you know, above which you're starting to get that accumulation of those morphine metabolites. I don't know the answer to that question specifically, but I would say just in terms of creatinine or EGFR, once the EGFR to me starts to fall below 50, well, perhaps certainly 30. If it's starting to fall below 30, I may not use morphine at all because I'm conscious that those metabolites are building up. Or if I am going to use it, I'm going to use it as we discussed, small doses, widely spaced apart. Yes, but that's an interesting question. What would be the tipping point in creatinine?
Yeah, thank you. I also want to clarify that in India, most of the palliative care units have only morphine as the strong opioid available. So we should continue to use it, but be careful with the very small doses and widely apart. So that's
the answer. I totally agree with what you've just said, and I think that what's happening is that there's perhaps internationally there's a recognition of what you've just said, the truth of what you've just said, because previously authorities were saying don't use it, you cannot use it. The difficulty with that is the very situation you're describing, where morphine is the only strong opioid available. So I think that just like in Africa, where they talk about renal dose morphine, just in India, yes, you can use it, but small doses, widely spaced apart, and then see how things go. And monitoring for side effects, of course.
Can you explain the use of sodium carbonate for adding taste or to produce taste?
Yes, it's an interesting thing, exactly the role of the sodium bicarbonate, because you've already got an elevated bicarbonate there. As to the mechanism, as to why it seems to reset or whether it's, particularly even cleaning the mouth, clearing the mouth, resetting perhaps those taste receptors. Maybe, look, we don't know the full mechanism of it, but it seems to be a mouthwash with sodium bicarbonate prior to meals seems to allow the person to have a bit more taste through the meal. But as to, this has really been not studied particularly well, apart from the observation that sodium bicarbonate did help.
Yeah. What about the parental nutrition in CKD patients?
That's an interesting question, isn't it? Parenteral nutrition. So I would not be an expert at that. So I've rarely seen it, as in nasogastric or PEG or TPN, these sort of ways of feeding. Yes, that question I would probably sit with a renal dietitian and a nephrologist and talk to them, because no doubt that there'd be issues in terms of the amount of volume of those feeds. That may have a critical aspect, and also the electrolyte balance of everything. So I think that there's probably a complex nature, a complex answer to that question about parenteral. I don't see it often, but I guess if it were to occur, you'd really need to sit with a nephrologist and a dietitian to work out how safe this is.
There is another question asking about depression is common in CKD patients and leads to poor appetite. How to identify? I'm not sure whether to identify the depression or depression leading to poor appetite, and how to identify the cause of appetite.
That's a really interesting question, isn't it? Because yes, the DSM classification or the criteria for major depression includes loss of appetite. And yet kidney patients, many of them have loss of appetite anyway. So just with cancer, you probably know that story about cancer and major depression, where there's been a move away from simply using those physical symptoms as the criteria for depression, but more things in low mood, feeling of unworthiness, hopelessness, or even suicidal ideation. A similar story, I think, has come into renal, because we realise that so many of our patients are tired, have sleeplessness, anorexia. Now, you need to be conscious that that's a physical story for these patients, and it may not necessarily reflect depression. So I think it's perhaps moving to those other aspects or other indications of major depression where the psychiatrists are now moving, that those sort of deeper feelings, if you like, loss of enjoyment, low mood, all of those things there. I think, yeah, so certainly in the next lecture, I'll be turning to depression.
Yeah. Dr. Sugandha is asking, what should we do when patients' taste buds are dead and the patients are not going to eat anything?
So I'll just hear that question again. What do we do when the patient?
Yeah. What should we do when patients' taste buds are dead?
Oh, I understand. Yes. Well, I guess that's a very interesting description. The taste buds are dead. Patients can describe that my taste is completely gone. Look, I think the first thing to do is acknowledge it, because often patients feel that no one is really listening to them, or the doctors are maybe not even focusing on this. So I think acknowledging that and saying to them that this is a fairly common, not everyone, happens with kidney, so people realise that it's probably the kidney disease. Then what I do is say to them, if they feel they've got no taste at all, why don't we try, and usually getting the family in, why don't we try changing the diet a bit to see if we can bring some more taste to bear, bringing in things like chili or spices or vinegar, or cooking with lemon or lime, or maybe with a bit of honey. These sort of things to try and stimulate a bit of a bit of taste, in addition to perhaps the sodium bicarbonate mouthwashes.
Yeah. There is another question regarding the use of trasitat. I think it's megestrol acetate.
Oh, okay. So Okay, so that's an interesting question about the use of medroxyprogestogen. Is that right?
Magistrol acetate.
Oh, now, as an appetite stimulant, I wonder what they're thinking there.
Yeah. Is it?
I haven't had. It's a good question. I haven't had experience using that. I just, whenever I'm coming into it with a new medicine using, I'll always talk to the nephrologist to say, what do you think about this medicine? Because I just need to be careful it's not going to interrupt blood pressure or fluid status or anything else like that. So I can't comment on that, but it's an interesting question there that person's asked.
Okay, so I think that's about questions, and there is another question on parental nutrition. Um, is TPN, total parental nutrition, good for patients whose taste buds are totally dead and the patient is going weaker day by day?
Yeah, so that would be, yeah, as I said, I've had little, if any, experience in parenteral nutrition in these patients. I think it would need to be very carefully, well, it either is not used, and I think there may be some reasonable reasons not to use it, but you'd have to be careful as to exactly what you're trying to do here. It may be that the person is now naturally deteriorating and natural death is approaching, and there may be a reason not to intervene, really. Yeah. One last question there. Someone has said, is tramadol not safe in CKD? Well, okay. So Sarah Davidson has put a question mark above it. Though it's still used, but in reduced doses. And the safety story appears to be the serotonin syndrome. That's where the safety story seems to lie. So if you follow Sarah Davidson, you wouldn't use it. Some other clinicians may use it, but in reduced doses. But thank you. Thanks so much.
Okay, I think this would be the last question. I think. Can we use morphine in living?
Yeah, good question. Can we use morphine in uremic encephalopathy? Well, gee, at that very moment, as uremic encephalopathy is coming in, this kidney function is very, very poor. So you'd have to be extremely careful. I mean, you could use it, but again, maybe even more widely spaced apart, maybe every 12 hours or even more. Yes, you'd have to be careful that you didn't tip the person into opioid toxicity in a uremic encephalopathy story. That's obviously not good at all. So you probably need to make the morphine dose even more widely apart.
So I would like to wind up the session, and I think the most important points from this session are what are the safe opioids in renal failure? So the answer is methadone, fentanyl, and buprenorphine. But those who have only morphine, we can continue to use it, but in small and widely spaced doses. And paracetamol is a safer option, whereas NSAID, we may not be able to use it. But if for those patients who doesn't have any renal function remaining, so in such patients, NSAID may be used. And regarding sleep, all of you might have heard about the melatonin, which can be used to re-establish the circadian rhythm. And regarding taste, I think that is one of the most attractive slide in Frank's presentation. How to treat when patients have taste alteration, what can be done, but you can also see there is no much evidence, but we can do something for taste alterations. So I think that would be the summary. And thank you, Frank, for joining us and enlightening us with the importance of managing symptoms in chronic kidney diseases. Thank you. So over to that, and thank you everybody for joining.
Thank you, Dr. Sunil Kumar. Thank you for chairing this meeting and taking all those questions. I really appreciate. And thank you, Pallium India, for organising this whole series. It's been lovely to have this contact with everyone.
Thank you, Dr. Frank and Dr. Sunil, for the session. Thank you all for joining today. So we can see you next Friday. That would be our last session. So I request all to join without any fail. Thank you all. Happy weekend. Bye.
Happy weekend to everyone. Thank you so much.